So I thought that what I would do is just give you a little bit in terms of the orientation to where standards, particularly as they apply to CT and radiation dose, are in the Joint Commission's armamentarium of standards. So I've got nothing to disclose. That's sad, but true. And I'm ready to start. So next slide, please. So these are the objectives that I thought we could look at. I want you to become familiar with the standards that particularly relate to radiation dose. I know that we're specifically looking at CT, but there are a few that apply, for instance, to fluoroscopy. And I want to talk a little bit about what the intent is behind some of the standards so that people understand why they're there. And then last, I thought I would bring up the change in the sentinel event definition that's been put out this year. Next slide. So people often say, so where are the imaging standards? Well, there's not a chapter that's labeled imaging in the Joint Commission standards. They are in, let's see, that's 7 chapters for the most part. That's where most of them can be found. And I thought I'd just walk through the chapters and tell you what's there, how they're applied for the most part, and what surveyors are looking for each of them. So let's go to the next slide. Is my volume okay? I'll assume in the absence of a comment, it is. So go on to environment of care. That's the chapter that's really looking at the physical environment that care is provided in and the equipment with which you provide that care. So of this, because I work with, we've changed our name. We're not the Department of Engineering anymore. We're the physical environment team. There are a lot of standards that apply to the physical environment and the equipment. So imaging is really just a very small part of that. Next slide. So the first thing I'm going to look at is the standard that addresses risks and management of risks within the physical environment. And we use numbers to designate the standard, and there's a little more involved definition of what management of risk is and what that standard says. But within that standard, that's sort of the general, here's what we're looking at. And then within that standard, we have things called EPs, or more specific elements of performance, more specifics that deal with what we would like you to look at in terms of meeting the requirements of the standard. And I wanted to let you know as we go through these, because if you've looked at the Joint Commission standards texts or the online standards lists, there are hundreds of them. And so in September of last year, our new president and CEO, Dr. Jonathan Perlin, said, we're going to look at all these standards, particularly in light of the struggles that organizations are going through now since the whole COVID issue and the public health emergency. So all of the standards have been reviewed, and I wrote down numbers. I think these are still current. The first go through of all the standards yielded 168 that were either deleted or termed to be duplicative. And so they were already involved in the definition of another standard or in an EP related to another standard. So last year, we took out 168 of them. And then we went through a second approach the beginning of this year, and 200 more were removed. And basically, the standards we're looking at are ones that we think are over and above what the conditions of participation are for the CMS deeming process, which this Joint Commission is accredited to provide. So we essentially are doing surveys for CMS. and they have to approve anything that we do. And often we looked at a particular circumstance and we said, well, here's what CMS requires, but we really think we ought to look at this as well. And we've decided to kind of pull back on some of that. So the criteria we're using as we're doing these reviews are that, first of all, the standard or EP can't be related to a state or federal regulation. It has to have been in effect for at least 3 years. And in the time period from 2017 to 2019, so it's only a 2-year period, but it was prior to the public health emergency, we're checking to see how many times that particular standard and EP were scored. And if it's less than 5 times in that period, we're then doing a more in-depth look to say, is the benefit of having this there worth the cost and the risk, if you will? Can you go back a second? Go back to the previous slide. So in this one, I got carried away. 020201, we have 3 EPs that are particularly appropriate for safety and risks. And these specifically deal with the provider of care, the worker, if you will. So first of all, EB7 talks about minimizing the risks associated with hazardous energy sources. And under that is the consideration of providing personal protective shielding during procedures, specifically fluoroscopic procedures. And we all know that a real source of staph exposure is interventional and surgery. And so surveyors, particularly when they're doing a tracer that goes through those areas, look to see that people are using aprons, thyroid shields, etc. So that's something that I see scored periodically, not horribly often, but periodically. Staph dosimetry reports. So 18 is really based on a CMS requirement that says that anyone classified as a radiation worker in the healthcare environment, hospitals, needs to be checked periodically for radiation exposure. So that's the one that says you need to have a badge or other equivalent monitoring to determine what your radiation exposure might be. So then we say in EP17, well, not only do you need to monitor these people, you need to look at the report, and it needs to be reviewed at least quarterly. So this is a focus on staff, and it's a focus on looking at meeting a CMS requirement and, kind of going the next step. Next slide. So still in the risk, medical equipment risk this time. So you notice it's a little bit different number. This is not ECO 20201, it's ECO 20401. And this is looking at equipment. And it says that in EP5, if you're what we consider an organization who's having a deemed survey, if you're a deemed organization, it means you have applied to the Joint Commission to have a survey done if you receive Medicare, Medicaid funds, and you're going to have Joint Commission do it in place of CMS. Now, that doesn't mean CMS won't come in. They pick a certain random sample of surveys that the Joint Commission does and does a second survey, and then we get a discrepancy report. And the idea is that our survey has to match the CMS survey, what they would see if they went into that organization. Because it's different time periods. We sometimes have discrepancies that are like, well, yeah, but not really. But still, that can happen. Okay, so ECO 20401 EP5. It says if you're one of those organizations that we're doing a survey for CMS, you need to have maintenance and inspection testing of your medical equipment, which includes imaging. Imaging equipment is classed as medical equipment that follows manufacturer's recommendations. So one of the things that a surveyor often asks is, do you know what the manufacturer recommends? And how do you know that? Do you have the manufacturer's recommendation someplace? So that's something you might consider when you're involved in a survey. EP10 says that you need to put some sort of a QC maintenance a plan together, and that should include the frequency with which you're doing those activities. So that says make a plan. Next slide. ECO 20403 pretty much says, well, you made the plan, now follow it. So EP 15 says that you're following your maintenance quality assurance quality control plan and that you're documenting that you're doing it. So they're going to ask to see the reports. And then we have, a couple of EPs that are focused on CT only in the imaging armamentarium. And then there are some that focus on nuclear medicine, PET, and then our latest kind of, dip is into fluoroscopy. So you notice there's nothing here that just deals with straight radiography. So EP17 says that, we're all relying on some of these numbers that are coming up on our screens when we do a study. And if you're using the CDDI as a measure of exposure to the patient, we all know it isn't, but if you're using that as a surrogate, we want to make sure that what you're seeing is reasonably accurate. So we say that the displayed and the actual, what your physicist measures, needs to match within 20%. I know some manufacturers say 30%, but bad news. The Joint Commission says 20%. Then, if you look at the next four, those are talking about annual performance evaluations. Those are tests that a qualified medical physicist or nuclear medicine scientist or MRI scientist can do to look at how well your equipment is performing in those imaging modalities. Now, there's a difference, although if you go through the manual and you look at exactly what's being measured, you'll say, gee, this is an awfully lot like what ACR accreditation looks at. Yes, they're pretty much the same parameters. The big difference is that ACR tells you very specifically how the physicist is going to do that test. The Joint Commission says they're the professional. They should know what they're looking for. We'll let them determine how they're going to measure these performance parameters. So that's a difference there. Next slide. Oops, I don't know what that was. Okay, next slide. Not only the equipment has to behave and operate correctly, but you got to have the people operating the equipment knowledgeable. And, here's a great place to learn how to operate your equipment appropriately and with up-to-date protocols right here in this educational opportunity. So Human Resources is the chapter that talks about people who operate the equipment. HR 10101 is just general, and that says your organization needs to define and verify staff qualifications across the board. And there are several EPs under that, and they say that you need to verify those staff qualifications and define them specific to the job responsibilities and activities of the person doing those jobs. So that, is broad, but it also covers anybody working in imaging. Notice that we talk in EP 32 about the qualifications for what? Oh dear, how's this happening? Because my battery saver is on. I think I'm plugged in. I don't know what that is. Anyway, it says that we have specific qualifications for the CT technologist or the operator of a diagnostic CT unit, but we don't have qualifications, and we have some we're going to talk about for the physicist that performs the performance evaluations, et cetera, for CT. But we don't have anything out there that specifically addresses the radiographer or the ultrasonographer or, any other imaging professional. So EP 32 addresses the qualifications of the CT technologist. And you may remember that originally we said that individual had to have an advanced certification in CT from either ART or NMTCB. That was changed, and I put the date down, I think I forget the exact date. I did write it down, but I don't know where I put it. Anyway, about less than a year later, we went ahead and changed that and said, wait a minute, we're going to allow some other ways for people to have the appropriate qualifications. And so, yep, you can still have advanced certification, or you can be state licensed in CT that permits performance in radiography that allows performance in CT, or you can be ARRTR and have documented training. State licensure also requires documented training in the performance of diagnostic CT, or you can be an MTCB ARRT documented in nuclear medicine and have documented training. Now, again, we don't tell you what that training has to be. We leave that up to the organization. But if a surveyor asks you to show them what you've been doing in order to provide that education, it better be fairly comprehensive. Okay, ongoing education and training. So we also had a standard that says you got to be oriented to your job, and your education and experience training needs to be verified with the previous HR standard. This says that periodically you need to refresh people's education. And initially, when the fluoroscopy standards came out, we had an annual requirement for individuals who operated fluoroscopic equipment. Well, we heard a lot from the physicians on that. No one had a problem with the technologists doing annual education, but the physicians. So we looked very hard at all of our HR standards and said, you know what, fluoroscopy education fits in a number of these standards. For instance, HR 010503 EP1. And so it doesn't mean that you just forget about fluoroscopy education. It means it's there. And the organization ought to be looking at the people who are operating fluoroscopic equipment and make sure that they are competent and knowledgeable in performing the studies and operating the equipment. So the only one that we have here, well, there's really two. EP14, which is for CT technologists, and I think it's EP15 for MRI technologists or operators, and they do have an annual education requirement for CT. It's that you're looking at dose optimization techniques and that you know how to safely operate your equipment. And this is particularly important if you're doing software upgrades. So there's the education. Next slide. Oh, here's the competency part. Again, some of the things that we thought addressed the notion particularly of fluoroscopy education. So HR 10601 says your staff is competent, and you have to have some way of determining that. And it has to be assessed initially and then at least every 3 years by the organization, or if your policy says that it has to be assessed more often, that you're following your policy. You know, that's one thing I will say about Joint Commission surveys. Know what your policies say, because a surveyor will look at that policy and then survey to your policy. So it's kind of like, you know, plan your dive and dive your plan. If you say you're going to do it, do it. Next slide. We have some standards in leadership. And I was particularly, I have proud of this one. I had a lot of influence here. And so we got a standard element of performance inserted into LD 040105 that says, and you can see it's been there since 2019, that says that the organization needs to designate a radiation safety officer. Now, this can be, but it's not necessarily the same person who is your capital R, capital S, capital O radiation safety officer that's on your Nuclear Regulatory Commission license. This could be another person, could be that RSO, but it can be another person that the organization designates for this role. Now, clearly that individual needs to have the authority and ability to provide leadership and support as the radiation safety officer. So they need to get that from the administration of the organization. And we've got some things that we would like them to look at. We're thinking someone, J. Edwards Deming said, if everyone's responsible, nobody's responsible. So here's where we're saying have an individual who's responsible to look at radiation use and exposure in your organization. So they need to make sure that dosimetry program is operating and that it's being reviewed and that action is being taken when it indicates that it should, that an individual is perhaps being exposed more than their coworkers in a particular area, or that, a specific area, for instance, interventional radiology, might need some special observation and recommendations on how to keep those individuals who work in that area's exposure as low as reasonably achievable. That person should also know enough about radiation safety to make some suggestions, like I just mentioned, in interventional, for instance. And if they do see something that they feel is unsafe or could be improved, they have the authority to get that done and to implement corrective action if they see these unsafe practices going on. Next slide. Okay, we have a section called Provision of Care, Treatment, and Services, or PC. And we have a number of standards and EPs that fit imaging. So for instance, PC 10215 says that the organization provides for diagnostic testing. And EP5 says that you're documenting some value that gives you an indication of what kind of radiation exposure you're submitting your patients to. So we let the organization decide what they're going to use as their value. CTDI pops up. It's pretty easy to use, as is DLP. You might have a scanner that allows you to actually get the size-related parameter, SSDE. And EP5 says that every diagnostic CT study has to have these values that are specific for the exam, that they're summarized over the series or anatomic area, and they're in a retrievable format. Now, lucky for us, I think probably every CT scanner out there now gives you a summary page at the end, and that's what goes into your PACS system. And that's very appropriate to meet this element of performance. Now, it's possible that a surveyor will say to you, hey, pull up one of these reports out of PACS and let me see that it's there. Let me see that, it looks like a reasonable number. Now, surveyors clearly don't have the knowledge that you do. And so they're not going to be able to evaluate those numbers maybe as well as you hope they would. But, they're going to be able to get a sense of what's going on. EP10 says that for all those advanced imaging modalities, CT, MRI, nuclear medicine, PET, prior to actually performing the study, the operator takes time to verify that they've got the correct patient. Of course, you're going to do that. That's, the red rule or whatever you call it in your organization, that they've got the correct imaging site. So they looked at the order, they know what they're doing, that they're going to position the patient correctly. And I know somebody's going to tell you about putting the area of interest in the middle of the field, and that you're picking the correct protocol for what it is the doctor would like to see, and that you're picking the correct parameters. So this doesn't mean that you have to document this. It just means that you've got a policy that talks about doing it, and that you, in fact, are able to tell that what do I recite the policy to the surveyor and say how you use it, how it fits into your process. The same for EP12. It says that you consider the patient's age. If it's a PEDS patient, depends on the size of the PEDS patient, whether they've had prior studies, and whether what's being ordered by the referring physician. And, AUC is put off again. So that's the most appropriate imaging modality for what the referring physician is looking for. So again, you don't have to record anything, but you need to have some kind of policy that says, yep, we're looking at that before we start the study. Next slide. So we did have, as I pointed out in 2019, some fluoroscopy EPs. And so we have EP13, which is very much like the CT EP, looking at a standardized value to approximate patient exposure. And so we're asking that for organizations that are doing fluoroscopy, that you document in a retrievable format the cumulative air kerma, the DAP, kerma area product, KAP, for that patient. Now, again, some units will do that for you, kind of like the summary page, and you can put that in PACS. Others, you may have to actually enter it into the patient record. And if you don't have a fluoro unit that does that, and by the way, that's standard on fluoro units since 2006, so let's hope you have a unit that does it. But if in the event you don't, we ask that the fluoroscopy time, the beam on time, and that the number of spot fills taken is recorded in a retrievable format. Now, it doesn't apply to fluoroscopy equipment that's part of radiation treatment planning or delivery. I know there's onboard imagers now. And I can't read what I've got on the bottom of my slide there, but it also doesn't apply to, what's it say? Okay, don't know what I said at the bottom there. So here's a question I often get. How do you know if you've got a treatment planning system and the surveyor comes by and says, are you recording this, the fluoro, or have you done the performance evaluation for a CT? That only applies to units used for diagnostic procedures. How do you know you're able to do that? Well, here's the story. Look at what you're billing for. To me, that's a nice rule of thumb. Look at what you're billing for. If on that unit you're billing for diagnostic procedures, then you know that you're using it as a diagnostic imaging device. And it's subject then to the performance evaluation for CT, and if it's fluoro, for doing the monitoring of exposure. Next slide. Okay, here's two that I know you're getting good information in this unit for. Some great talks coming up here. And you've already had a couple of good ones, but there's some more good ones coming up. So EP25 says, for CT, again, specific for CT, that you have protocols that are current. That is, you didn't develop them 10 years ago and you're still using them. They're current, so you know what the current standard of practice is. You're learning here in the next 3 days, today and 2 more days. So you know what the current standard of practice is, that your protocol addresses the clinical indications. So you know that it's an abdomen CT for a kidney stone versus a something else, some other indication, liver mets, for instance. That it addresses whether or not you use contrast and how much and what kind, whether it's an adult or a ped protocol, and if you've got variations based on patient size and body habitus, they take that into account. Your protocols take that into account. We also ask that you come up with expected, it says CTDI range here, but clearly if you're using one of the other, um, uh, substitutes for exposure, SS, one of those, that you've got a range. Now, it used to be we were mostly worried at the upper end, but as you're going to hear in some of the talks, you need to be worried about the lower end as well. Do you not have enough radiation to get a diagnostic exam? So it's good to have a range that addresses both the lower end you feel is acceptable and the upper end, and that's the range you're going to look at. And that 26 says, okay, you made the protocols. Now review them and keep them current. Now, we say it ought to be a team approach. Not it ought to be, it will be a team approach. And on your team, you ought to have an interpreting physician for that service or specialty, the medical physicist who's looking at the equipment and your protocols, an imaging technologist who's knowledgeable. Now, I said lead here, and I think we wrote lead, but basically we're looking for the technologist who's most knowledgeable in that particular area, and that the group knows what the current standards of practice and types of equipment, photon counting, is being used. And the frequency of that review, we don't specify. That's left to the organization. But I'll tell you, if you go over 3 years, the surveyor's probably going to squint at you a bit. But how you do it, you might do so many years, so many months, it's up to you. Oh no, why is my battery running low? I don't understand this. Would you guys excuse me just a second? Let me make sure my cord is plugged in. Thank you guys. It wasn't. When I moved it, it pulled out. Sorry about that. Okay, so again, frequency, how you do it, and you don't all have to be sitting in the same room. I know Tim is going to talk, I think, on Saturday, and I know he's got some lovely ways of keeping your protocols updated. So his talk will be well worth it. Next slide, please. Okay, so for fluoroscopy, we're asking for sort of an analogy to what we've asked for CT. And that is, we said, identify some either total exposure or, if you're able to, skin dose. That's the biggie in fluoroscopy. Skin dose thresholds that when you review it, remember you needed to come up with a range that you were going to review the patients if you went over that particular threshold. So get these thresholds established, and if they're exceeded, then have a process that says what you're going to do. Going to bring the patient back and reevaluate them? Do you give them information to take to their physician? What are you going to do to see whether there are any adverse effects from that fluoroscopic exposure? Next slide. Performance improvement. So we have a couple of standards that deal with more data that you ought to be looking at. So EP6 says that, remember that range that you created in your protocols for the CTDI, DLP, SSDE, whatever you're using, that when you exceed that range, either on the low or the high end, and for the kinds of exams that were outside your range, that, and that by looking at some external benchmarks, that you're looking to see why that happened. Now, in my experience, and I've been out of the clinic for a few years now, but in my experience, usually when you were over on the upper end, it had to do with, the patient's size, inability to maybe get their arms up over their head, those kinds of things. It generally wasn't that the incorrect protocol was selected or whatnot. But still, you need to have that review, and maybe there's something you can do to improve it, some other positioning device that might help. So we expect that you will be able to show that here are the exams that exceeded our thresholds, and here's what we did about them. And if it was just patient habitus, a body habitus, if it's motion, you've documented that that's what it was, that you're not exposing patients because, you're stuck 10 years ago in your protocols. So for fluoro, same thing. You should review and analyze those instances when you exceed that threshold. And that threshold you probably set up because you believe you might see some skin effects from that fluoroscopic radiation exposure. Next slide. So we used to have a sentinel event that was what? I wrote that down too. Where did I put it? 1,200 rads. It just said that you had exposed the patient to, I think it was 1,200. No, it was 1,500. Okay, 1,500 rads. And that if you exceeded that, then this was a sentinel event, and you should do a root cause analysis, and that you should report it to the Joint Commission as a sentinel event. Now, it's not required that you report it, so the number that we see, and frankly, there were very few that were excess radiation exposure. Who knows what fraction of events that actually occurred were reported. The other thing is, well, what's the interval? Are we talking 1,500 at one time? Okay, we can see that. Is it if you got 1,500 over the course of 2 weeks because that patient had, several long, complicated procedures? It was just very difficult to say whether that number really was worth anything. So we did some looking and review, and I'll give you the background document that we use mostly in the next slide, but not yet. That we now have the definition of a sentinel event for fluoroscopy as being one that results in a permanent tissue injury. And here's the kicker: when clinical and technical optimization were not implemented or recognized practice parameters weren't followed. So it means you didn't, we all know that sometimes a physician gets into a procedure, it's much more complicated than they anticipated. It takes much longer, and they need more fluoroscopy for positioning of a device, for instance, than they anticipated. Or you've got a very large patient that's going to use more radiation in order to get a diagnostic study, and they could, in fact, exceed that threshold for skin effects. But you did everything right. There was nothing that was inappropriate in performing that study. So it's only in that case that you should report a sentinel event due to fluoroscopic exposure. Again, as I noted in the line under there, that 1,500 was, I don't know, it didn't really talk about the interval at which you acquired that dose. It didn't talk about all the, your error bars are this wide when you're trying to determine that dose. So, I think this is a much better definition. And we have one for radiotherapy as well, in terms of whether you are delivering more than 25% of the radiation dose, 25% above your planned radiation dose. And that's really in line with what most states ask you to report. Next slide.
Dr. Brown, this is Carly. Can you hear me?
Yes.
Okay. I'm just trying to keep us on schedule. And
I'm almost done.
Yeah. So I think we should wrap up by 2:30. And then if there are questions in the Q&A,
sure,
you can respond to them in writing.
Absolutely.
Okay.
So this slide, I'm really, truly almost done. This slide looks at documents that we used when we created the revision to the sentinel event. definition, and I would recommend that you look at NCRP 168, which talks about substantial radiation dose levels. Remember, we don't have any that we're prescribing, but this talks about what you might use, and it also talks about the process you might put in place to follow up on those exposures. Next slide. And I just put a couple articles in here just to let you know, all you have to do is Google this stuff, and you'll get a wealth of information. Next slide. So here's some dose optimization. Here's looking at pediatric doses. There's lots of numbers out there for you to get. So if you go to the next one, next slide, that's my disclaimer. You can read that when you get them. And next slide, this is my team. So we are the physical environment specialists who look at all of the environment of care, life safety, and emergency management standards. And we are part, just to let you know, we're part of a group in the Joint Commission called the Standards Interpretation Group. And you can write in questions. You can, during a survey, if you've got some issue with what the surveyor is looking at in terms of equipment or qualifications, you can always ask them to call the SIG Physical Environment Group. And we always have someone on call during the day and into the evening to answer those questions. So thank you. I probably, you're probably all asleep, but that's okay. Thanks a lot. I enjoyed talking to you. Looks like a great program, and you're going to get lots of that updated advice to help you meet these standard requirements. Thanks.